long-standing relationships with the land upon which the work of the University of Toronto Department of Medicine is conducted. We acknowledge our presence on the traditional territory of many Indigenous nations, including the Mississauga, the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, this land is home to many diverse First Nations, Inuit, and Métis peoples, and we are grateful to have the opportunity to live, work, and gather on these territories. Land acknowledgements are only a starting point for larger conversations. More concrete acts of restitution and transformation are needed to address underlying inequities and blatant discrimination in the distribution of resources between Canada's First Peoples and settlers. First up today, Dr. Guillaume Lim Fat, PGY4 and incoming chief resident, will present the REGAIN study. Guillaume, please feel free to share your slides and begin.
Thank you for the introduction. Okay. Okay, just thumbs up if that works. Perfect. So welcome everyone to Anesthesia Day at the Geriatrics Journal Club, where our goal is to not put you to sleep. And that'll be my only joke about anesthesia for the day. So I'm starting out with the REGAIN trial. I'm talking about regional versus general anesthesia for promoting independence after hip fracture. So this was published in the New England Journal of Medicine in November 2021, excuse me, under the title here, Spinal or Regional Anesthesia for Hip Surgery in Older Adults by Newman et al. The REGAIN investigators, which includes Toronto's very own Dr. Kijun Chin and Dr. Stephen Choi. Now, Dr. Chin was so kind to provide me with some commentary to share with the geriatrics group this morning. I did mention he'd try to make it if it allows, but the timing is difficult as this is prime time for setting up ORs. So I have no conflicts of interest to disclose. Objectives today will be to summarize the study design and findings, critically appraise the methodology and results, and discuss the study implications for clinical practice. Now, I apologize, I'll be going particularly quickly to allow for time for discussion today, but I'm happy to go back to any slides later on. So the background to this is that there's been a prevailing historical concern of greater overall risk with general anesthesia in older adults, particularly if frail or cognitively impaired. And there has been observational studies that suggest spinal anesthesia is associated with lower risk of adverse outcomes in patients undergoing hip surgery. But there's been a lack of randomized trials comparing spinal to GA with strong high quality evidence. And the authors of REGAIN in particular identified omission of independent ambulatory status as a patient-centered outcome. So they set out to answer, can a large randomized trial show that spinal anesthesia is superior to GA in patient-centered outcomes such as postoperative ambulatory status in older adults undergoing hip surgery? So in PICO format, this study looked at adults age 50 and older who were scheduled to undergo repair of a hip fracture at 46 hospital sites in the US and Canada. The intervention of interest was single injection spinal anesthetic with sedation adjusted as needed to ensure patient comfort. It's a little bit of a interesting point about this study that I'll talk more about, but they were targeting what is called an OAAS of 2 to 5, which is a measure of sedation. The control to compare to was general anesthesia with inhaled anesthetic agent for maintenance, with a choice of agents and airway management in accordance with local practice. And the primary outcome of interest was a composite outcome of death by 60 days post-randomization or inability to walk 3 meters independently. That was defined as with no gait aid, with a cane or with a walker at 60 days post. And they used the composite, including death, in order to account for survivorship bias post-op. The secondary outcomes of interest were the individual components of the composite outcome, but also any new post-operative delirium, which they detected by 3D cam for 3 days post-op and time to discharge from hospital. They also reported on a number of exploratory outcomes that I'll quickly go over. Now, the study protocol is a multi-center pragmatic randomized superiority trial. It involved looking at ED admission and OR lists at those 46 hospitals to identify eligible patients who were then randomized in a 1-to-1 ratio to either receive spinal or general anesthesia. It was stratified according to hospital, sex, and fracture location. Inclusion criteria, as I mentioned, 50 years or older, scheduled to undergo surgical repair of these three main types of hip fractures. Exclusion criteria included inability to ambulate independently at baseline, since this was their primary outcome of interest. Concurrent procedure required that's not amenable to spinal, like a polytrauma, periprosthetic fracture, risk of malignant hyperthermia, as that would preclude GA, contraindication to spinal anesthesia, and the main ones are bleeding diathesis, anticoagulation, risk of infection at the spinal ejection site. Or, interestingly, if they were deemed unsuitable for randomization just by the surgeon or anesthesiologist. It's an important thing to note. It means that patients had to be eligible for either anesthetic approach in order to be part of this trial. And they remained included if there was crossover following randomization, either due to clinical circumstance or patient request. And finally, patients with delirium at the time of randomization were still eligible, but they were, of course, excluded from the analysis of post-op delirium. I won't go into detail with the stats analysis. I just wanted to mention the use intention to treat. I can come back to this if anyone is interested. So now the flow chart of what happened, 22,000 patients were eligible and 1,600 underwent randomization. Out of those, 795 were assigned to receive spinal and 805 were assigned to receive GA. Interestingly, out of all those assigned to receive spinal anesthesia, only 666 actually did receive it. So there was a 50% or 119 patients that crossed over and received GA instead. And after that, there was about a 10% loss of data. And at 60 days, only 712 patients were included out of the original 795. On the other arm for the GA, 769 actually received GA, while 28 crossed over and got spinal anesthesia instead. And again, there was about a 10% loss of data at 60 days. Going into a little bit more detail about the crossover, because it's an interesting point in this trial. So in the spinal group, 119 patients, 15% crossed over to get GA instead. Out of those, just less than half was due to inability to place a spinal block, even though it was attempted, so they converted to GA. 29 was due to patient selection, 18 was because of patient or proxy request. On the other hand, there was much less crossover from GA to spinal at 3.5%. 15 of those was because of clinician selection, 7 or so were due to patient proxy request. Now, looking at the baseline characteristics, even though the age cutoff was relatively low for what we would consider older adults, the average age ended up being much more representative of what we see at around 78 for both the spinal and general anesthesia groups. Males made up about 33% of each group, representing the higher predominance of females in hip fractures. And just looking at the rates of dementia, they were relatively low, though they reported as equal amongst groups, 13.7% in spinal anesthesia, 11.7% general anesthesia. Other literature would suggest the rates of dementia in hip fracture patients closer to 20 to 30%. The baseline rates of delirium at randomization or before randomization were about 13% in each group, and the use of assistive devices around 32% for each group as well. Relatively low rates of nursing home being the residents at randomization at 8% and 9.6% respectively. All of which is to stress that this was a relatively not frail group. Now, the results showed that there was no significant difference in the composite primary outcome they were looking at of death and inability to ambulate independently at 60 days between the spinal and the GA groups at 18.5 and 18% respectively. Secondary outcomes were also similar between groups. So postoperative delirium occurred in 20.5% of patients assigned to spinal, 19.7% of patients assigned to GA. Looking at those in more detail, so the primary outcome I talked about, the secondary outcomes, so they separated the primary outcome, which was a composite, into the two separate things. So either death by 60 days, that happened in 3.9% of the spinal group and the 4.1% of the GA group with no significant difference between them. Inability to walk independently. So again, this was either with no gait aid, a cane, or a walker. That was in 15.2% of the spinal group and 14.4% of the GA group. And the onset of delirium postoperatively, it was 20.5% in spinal and 19.7% in the GA group. They also looked at the median time to discharge, which they stratified by country. And again, there was no significant difference between spinal or general anesthesia, around 6 days in Canada and 3 days in the US. They also did some subgroup analyses for the primary outcome specifically. Of most interest to us was when they did subgroup analyses by age, so either less than 85 or over 85. There was also no significant difference between spinal and general anesthesia rates when it comes to the primary outcome. But of course, the primary outcome was more prevalent in the older group of over 85. Sorry. Now, the exploratory outcomes, I mean, I would stress that the study wasn't quite powered to comment on these, but the ones they did report, incidence of death during hospitalization, acute kidney injury, and postoperative ICU admissions were greater in the general anesthesia group, but low overall. So other adverse and exploratory outcomes, though, were similar between groups. Looking at those in more detail, so the ones that where there was a significant difference between groups, first one was death in hospital specifically. So remember that at 60 days, there was no significant difference between groups, but death in hospital was more likely in the GA group at 1.6% compared to 0.6. Risk of acute kidney injury likewise was higher in the GA group at 7.6% compared to 4.5 in the spinal, and critical care admission at 3.7% compared to 2.3. Now, with all that, the authors concluded that spinal anesthesia was not superior to general anesthesia with respect to risk of death or new ability to walk independently at 60 days. They also commented that the incidence of new onset delirium and hospital lengths of stay were similar between the two types of anesthesia. For the critical appraisal, using our usual CEBM framework, we'll go through these questions. Was the assignment of patients to treatments randomized? Yes, by design. Were the groups similar at the start of the trial? Yes, looking at table 1, they were. Aside from the allocated treatment, were groups treated equally? Yes, with some limitation. The big contentious one here is the use of sedation in the spinal anesthesia group. And there was variability in terms of what sedatives were used and what was the degree of sedation that was reached with each individual patient, and a lot of individual practices variance by a hospital site. Were the patients analyzed in the groups to which they were randomized? Yes, with intention to treat analysis. Were all patients who entered the trial accounted for? Unfortunately, no, there was a 10% loss to follow-up rate. And that's much more than they intended for or that they projected at the start of the trial. They did the power calculations anticipating 5% loss to follow-up rate. And in fact, it was about double that at 10%. Were the patients and clinicians kept blind to which treatment was being received? No, unfortunately, unable to do so with the nature of the intervention. Were measures objective? Absolutely. Are the results of this study internally valid? Yes, I'd say with limitations. So the loss to follow-up being one. The other thing was that in their power calculations, they anticipated a much higher rate of the primary outcome at around 32%. That's what they were expecting, when in fact, we got about 18% cumulative incidence of the primary outcome. Finally, will the results help me in caring for my patients? Yes, if my patients are eligible for either. I think this gives us great information to share with them. So going to a few strengths. First of all, it's the largest randomized study of outcomes with regional versus GA, providing highest level of evidence so far. I like the pragmatic design that allows for crossover. It reflects the need for flexibility with anesthetic choices and the dynamic nature of anesthesia. I like that the primary outcome is patient-centered. And I do like how the findings allow me to make my patient preference at the forefront when either approach is an option for them. Now, the limitations, I do think frail older adults may have been underrepresented. The age cutoff was a bit on the low side, though the average age was closer to what we see at 78. They had to be independently mobile at baseline, and there was a low rate of dementia overall. There's significant loss or crossover and loss to follow-up that I've already talked about, and there's the variable sedation in the spinal anesthesia group. So in the patients who received spinal anesthesia, it was 666 of them, only 500 actually had data on the depth of sedation there. But in those where data was available, 86% of them were on target, 14% had deeper sedation than that. Delirium detection was limited to post-op day 3, and as geriatricians will know, delirium occurs much later than that in a lot of cases. But I can see how, if they wanted to know the direct effect of the anesthetic type, they would want to limit it to closer to the operation. They also didn't report on postoperative pain or opioid use, and I would have been interested in that data as it ties to delirium risk. There's also no stratification of analysis by hospital site. In a study where there's going to be inherent variances by hospital site, that would have been nice to see, but I understand that recruitment was too low at several sites in order to allow for this. Okay, we can't talk about Regain without talking about RAGA. This came out in JAMA a few months later by Lee et al., and it actually addressed a lot of the criticisms that Regain had. So they looked at patients over 65 and older, again, randomized to regional or general anesthesia, but their regional group had no sedation. And they looked at delirium as their primary outcome over 7 postoperative days. So this is what their study was powered to look at. and they found no significant difference between groups when it comes to delirium. There are criticisms for RAGA as well. I won't go into too much detail, but one of them was the low rates of delirium overall at 6.2 and 5.1% respectively. So that's it for my summary of REGAIN. I will just quickly check in and see if Dr. Chin was able to make it. Otherwise, I'll share the commentary on his behalf.
Dr. Chin.
Okay.
I don't think, go ahead, Guillaume. You
have a
few more minutes.
Yeah, so Dr. Chin shares this with us. As with any individual aspect of healthcare, both spinal and general can be of varying quality. So many now accept that whether spinal GA is administered does not matter as much as whether attention is paid to preservation of homeostatic physiology as far as possible. For REGAIN, remember that all patients included had to be eligible to receive either technique. Even though there were a limited amount of absolute contraindications and exclusive criteria explicitly stated, on the ground, we were often not recruiting patients in whom we suspected colleagues would not be comfortable with one of the randomized approaches. So the study patients are a rather select group. There are going to be patients in whom we would judge one of the options to be better than the other. Take-home message, spinal or GA does not appear to matter to major outcomes in patients without contraindication to either technique. Note that there will be a secondary paper coming out in Annals of Internal Medicine reporting on pain and patient satisfaction. There's statistically higher pain and opioid use in the spinal group, but I do not believe it is clinically meaningful. What is more important is that a majority of patients have severe pain post-op. It could be that recovery can be enhanced with more attention to analgesia, post-op, and opioid-sparing strategies. Regional anesthesia in terms of nerve blocks rather than spinal anesthesia per se may have a role to play here. Okay, so that concludes the commentary he wanted me to share. Happy to have some more discussion and questions at this point.
Thank you very much, Guillaume, for the excellent, clear, and efficient presentation, and for taking the time to gather the extra commentary from an anesthesiologist. Gary has his hand up. Go ahead.
Great job, Guy. I really enjoyed the presentation, and good to see you. I have just a couple comments. So you did a nice job pointing out some of the limitations, and there was a loss to follow-up that is fairly high, and it's hard sometimes to assess the impact that may have had on the results. So the question about that is, did they provide a table that compared the characteristics of the people that were lost to follow-up compared to the people who were not lost to follow-up? Because sometimes that can give you a sense as to how that may have influenced the result.
I believe it was included in one of the appendices. I have to admit, I didn't go into that much detail to look at those particular characteristics. One thing I did forget to mention is that they use something called inverse probability weighting to try to make up for any lost data. But of course, you can't make up for lost data completely. And actually, I do see that Dr. Chin has joined. Thank you for joining us, Dr. Chin. Please feel free to unmute and contribute to any of your insights to the commentary.
And just my second comment, you talked about power with respect to the exploratory analysis, and even though, as you pointed out, this was one of the larger studies that's been done with this type of comparison, I'd urge you to look at the confidence intervals of your results in the main results table. And I asked the question that I often do you feel that this was a definitive study in terms of its result? And that what I mean by that, you have tight enough confidence intervals that you don't think there is a possibility that you missed what would have been a clinically important difference. And I would suggest that the confidence intervals actually were quite large. And I'm not sure that I am confident that we could exclude the possibility that there could have been a clinically important difference that could have been missed, even though in general terms, this looks like a fairly large study. Thank you, Guy.
Thank you.
Thank you, Gary. Shabir has his hand up. Go ahead.
Thanks, Dov. Great presentation, Guillaume. And I was going to say something very similar to Gary in terms of how negative is a negative trial. And there's a whole literature on this in terms of, can you have confidence in a negative study, whether it's an equivalent study or a study that ends up concluding that there is no difference between the groups in outcome X, such as delirium. And I agree with Gary, the confidence intervals are not that narrow. On the other hand, the only other 2 points I'll make is, although Gary's absolutely right, the second trial that you presented and the totality of not the totality of evidence, but the strongest quality of evidence from the randomized trials to date, not just this one, but the other one and some other emerging data, do seem to be consistent in suggesting that there is no big effect on delirium, which is somewhat reassuring. And at a pragmatic level, I'm not sure if anyone else is going to try to do more trials with an even bigger sample, get more money to try to make an even narrower confidence interval. So pragmatically, we're probably stuck with this level of evidence and accepting that there probably isn't a big delirium difference between spinal versus general in these populations.
Thank you, Shabir. And Guillaume, perhaps I have one more question. You mentioned the 15% crossover and the explanation or detailed analysis. In everyday practice, do you have a sense of how many people fail spinal and need to proceed to general? Not in the trial, but in everyday practice?
Yeah, no, I didn't look at the primary literature citing that level of evidence myself, but in the commentary for this paper, and there was a lot of subsequent letters to NEJM about this paper, they do mention, the authors did mention that this is similar to rates of crossover that they see in practice.
Great, thank you. So Dr. Chin, thank you for joining. If you'd like to unmute and share a comment, if not for time purposes, we'll have to move on. Presentation. Next, we have one of our geriatric medicine fellows at UHN Sinai, Dr. Marie RCT. Dr. Bonella, please go ahead.
Thank you so much for the introduction. It's a pleasure for me to have the opportunity to present this journal club. In the next half hour, we will discuss the following trial, which evaluates the development of delirium in elderly patients following the use of 2 different anesthesia strategies during major surgical procedures. I have no conflicts of interest. Well, the main objectives I will address during this presentation include a brief introduction to what we know so far about postoperative delirium. Then I will present the selected paper. And finally, we will discuss the clinical appraisal and relevance of postoperative delirium in our daily practice based on the results of this study. As you all probably know, delirium is an acute syndrome of brain dysfunction characterized by fluctuating disturbance of concentration, consciousness, and cognitive function. Postoperative delirium is common in older patients, with an incidence that varies widely depending on the patient population and the type of surgery. As you can see from this slide, previous research has found an incidence of postoperative delirium after cardiac surgery ranging from 6 to 46%, similar to the incidence in gastrointestinal surgeries. In the case of orthopedic surgeries, postoperative delirium has been observed in a range between 5% to 70%, depending on the procedures. But beyond the incidence, I think we will all agree that the relevance of this issue lies in the fact that delirium is associated with worse perioperative and long-term outcomes, including prolonged hospitalization, multiple complications, lower odds of being discharged home, as well as increased hospital readmission, lower cognition and functional status, and lower quality of life. As you know, delirium involves a dynamic interplay between pre-existing vulnerabilities and pre-existing insults. Although some risk factors are unmodifiable, many can be minimized, such as uncontrolled pain, anemia, and infection. In post-surgery delirium, causes and potential mechanisms leading to delirium development are multifactorial. However, the most relevant may include severe pain, use of high-dose opioids, as well as surgery-related stress and inflammation. Interestingly, the type of anesthesia has recently begun to be considered one of the potential modifiable factors. But which is the rationale behind the impact anesthesia might have on the delirium development? Well, as you know, and as you can also review in this slide, aging is associated with a progressive loss of functional reserve in all organ systems. And although there is considerable individual variability in the extent of changes related to aging, even the healthy older adult has reduced physiologic reserve. And therefore, all older adults may have a certain degree of organ system compromise when exposed to surgical stress. In addition, we should also keep in mind that physiological changes can specifically affect anesthetic care, in part because they may lead to an increased susceptibility to anesthetic drugs. The aging process will affect the pharmacokinetics and pharmacodynamics of many drugs used before, during, and after surgery. Compared to young patients, elders tend to have more adipose tissue, decreased body water, and less muscle mass. These changes will cause water-soluble drugs to have decreased volume of distribution, whereas lipid-soluble drugs may have increased volume of distribution. In addition, clearance for most drugs is decreasing in the elderly, and drug sensitivity, especially to anesthetics, is usually also increased in this population. Before continuing, I would like to briefly review the different types of anesthesia. Although I'm not an expert on this topic, I think it might be important to review some concepts quickly. As you know, general anesthesia is the use of an anesthetic drug to induce unconsciousness during surgery. In contrast, regional anesthesia is the use to numb the portion of the body that will undergo surgery. There are several forms of regional anesthesia techniques, but I just want to mention two of them. Spinal anesthesia, which is frequently used for lower abdominal, pelvic, rectal, and lower extremity surgery. This type of anesthesia involves usually injecting a single dose of the anesthetic drug into the area surrounding the spinal cord. The injection is made into the lower back, below the end of the spinal cord, and causes numbness in the lower body. This type of anesthesia is most often used in orthopedic procedures of the lower extremities. On the other hand, epidural anesthesia is similar to the former and is commonly used for surgery of the lower limb and during labor and childbirth. This type of anesthesia usually involves continually infusing an anesthetic medication through a thin catheter that is placed into the epidural space that surrounds the spinal cord in the lower back, causing numbness in the lower body. Epidural anesthesia may also be used for chest and abdominal surgery. In this case, the anesthetic drug is injected at a higher level in the back to numb the chest and abdominal areas. Regarding the advantages of those techniques, the single shot spinal technique has a rapid onset of block, reliable symmetric block, including sacral nerve root. It's associated with low doses of local anesthetics. And technically, I'm not an expert, but apparently it's easier. On the other hand, epidural anesthesia has different advantages, including the possibility to prolong the duration and extend block, relatively slow onset of the anesthesia, and may be used to provide postoperative analgesia. You will find this image in the next slide to compare the techniques used in each study that I'm going to present. Before we move onto the article of interest. I would like to present the research behind this article. In 2017, this meta-analysis assessed a series of perioperative outcomes, including delirium, at its association with the different type of anesthesia delivery. The authors included around 15 large observational studies, most of them comparing general anesthesia versus regional anesthesia, including spinal or epidural. They also performed a sensitivity analysis for spinal versus general anesthesia. Results show that there wasn't any significant difference in delirium frequency among the different types of anesthesia. Limitations of the study included the use of observational data and the lack of clarity in the definition of delirium. Later on, the RAGA trial was published in 2018 with the aim of investigating, as Guillermo said before, the effects of regional anesthesia on the incidence of postoperative delirium compared to general anesthesia in older adults undergoing surgical repair for hip fracture. The primary outcome was the incidence of delirium during the first 7 postoperative days. Secondary outcomes included more than 1 episode of delirium during the same period and 30-day mortality. In this trial, researchers compared GA versus regional anesthesia, including spinal, epidural, or combined spinal epidural techniques with no sedation. However, the researchers couldn't prove that the incidence of postoperative delirium was reduced with the use of regional anesthesia. We should, however, consider that there were some limitations in this study, including a small sample size and an observed incidence of postoperative delirium of 5% to 6%, which was much lower than expected. And it was considered unlikely that the trial could achieve the anticipated 30% relative reduction with a statistical significance. Other limitation was that the majority of participants were recruited from a single center. 1 year later, a retrospective population-based cohort with more than 1 million patients that went under total hip and knee arthroplasty surgery was published and showed that patients under regional anesthesia had lower odds of postoperative delirium. In this context of lack of a strong evidence on whether or not different anesthetic techniques prevent postoperative delirium, a research team from China decided to conduct a multi-center, open-label, randomized controlled clinical trial supported by the Beijing University Clinical Research Program. The author's hypothesis was that in older patients having major thoracic and abdominal surgery, delirium during the initial 7 postoperative days should be less common in patients given combined epidural general anesthesia with postoperative epidural analgesia than in those given general anesthesia followed by intravenous opioids. The authors consider that epidural analgesia has certain advantages in pain control, overall opioid consumption, and stress and inflammatory response, all of which might help to prevent delirium. The population included in this research consisted of patients ages 60 to 90 years old who were scheduled for major non-cardiac thoracic or abdominal surgery, expected to at least 2 hours, and agreeing to use patient control analgesia after surgery. The intervention was combined epidural general anesthesia with postoperative epidural analgesia. The comparison was general anesthesia with postoperative IV analgesia. The primary outcome was the incidence of delirium during the 7 postoperative days. Delirium being assessed with a CAM ICU twice a day. The day before surgery, the investigator checked the list of patients planned for surgery and their medical charts to identify potential participants according to their inclusion and exclusion criteria. They included patients aged 60 to 90-year-old who were scheduled for major non-cardiac thoracic or abdominal surgery, expected to last at least 2 hours, who agreed to use patient-controlled analgesia after surgery, as I said before. I just want to mention that patients with thoracoscopy or laparoscopy surgery were included when the expected incision length was at least 5 centimeters. The excluded patients had severe neurologic conditions, acute myocardial infarction or stroke within 3 months, any contraindication for epidural anesthesia, severe heart dysfunction, severe liver dysfunction, and renal failure. So then the research visited these patients and formally invited them to participate. Baseline data collection and measurements included the Bartley Index, the MMSE, levels of anxiety and depression measured using the Hospital Anxiety and Depression Scale, and delirium before surgery was assessed with the CAM ICU. The randomization was performed centrally at Beijing University Clinical Research Institute through an interactive web system on the day of surgery just before anesthesia. Patients randomized to the general anesthesia group had a standardized protocol and received post-surgery continuous morphine infusion. In the other arm, in patients who received combined epidural, combined epidural analgesia, epidural catheterization was performed first. Patient control epidural analgesia post-surgery consisted of ropivacaine and sufentanil. Although all anesthesiologists were experienced in epidural block techniques, they consider a failure rate of about 5%. Patients with unsuccessful epidural block received general anesthesia and postoperative intravenous analgesia. The primary and secondary outcome measurements and data collection were collected in both arms, and an intention to treat analysis was performed. With regards to the results of the study, around 3,000 patients were assessed for eligibility. In terms of exclusion criteria, I would like to mention 2 of them I consider relevant to our practice. One is that they excluded patients with Parkinson's disease, and the second is the exclusion of patients with severe dementia or a communication barrier. Around 1,800 patients were randomized and half was assigned to each arm. A similar number of patients were analyzed in an intention to treat analysis. After some protocol deviations in each arm, a quite similar number of patients were analyzed per protocol analysis. In table 1, we can see that the demographic and baseline variables were well balanced between the 2 groups, except for preoperative hypertension, which was less common in patients assigned to combined epidural general anesthesia, and lower creatinine concentrations, which were lower in this group. Patients had a mean age of 69 years, and 60% were males. Participants had low rate of comorbidity with a median Charlson comorbidity index of 2. Nobody had delirium before surgery day. Interestingly, the median mini-mental test score was 29, with a range between 27 to 30. Only 4% of patients had an MMSE score of less than 24. I should also mention that the Bartel index score was 100. At this point, I think it's important to highlight that there are missing data in some of the last variables I mentioned. And finally, although it was a multi-center study, 90% of the patients came from one center. Regarding intraoperative and postoperative variables, patients in the epidural anesthesia group received fewer opioids and anti-inflammatory drugs. Additionally, they had lower mean arterial pressure and therefore require more colloids. The incidence of postoperative delirium within 7 days was significantly lower in patients assigned to epidural general anesthesia, with 1.8% of delirium in this group versus 5% in the comparison group. The relative risk of delirium for patients with epidural general anesthesia was 0.35. The per protocol analysis showed similar results. Finally, the number needed to treat was 31. At this point, I think it's important to highlight that the absolute number of patients with delirium in the trial was 58, with 15 in the combined epidural general anesthesia group. All 3 subtypes of delirium were significantly less common in the epidural general anesthesia patients. Regarding secondary outcomes, among 20% of the patients admitted to the ICU after surgery, those assigned to combine epidural general anesthesia were 33% less likely to remain intubated, with an ICU stay duration about 5% shorter. Among all patients, moderate to severe pain was significantly less common in the epidural general anesthesia group on the first postoperative morning. Other secondary outcomes, including non-delirium complications within 30 days, did not differ between the 2 groups. Finally, regarding adverse effects, patients randomized to epidural general anesthesia had more intraoperative hypotension, spent more time with a mean arterial pressure lower than 65, and were more likely to require vasopressors. Over the initial 3 postoperative days, patients assigned to epidural general anesthesia were less likely to experience hypertension or postoperatorily nausea and vomiting. Regarding the critical appraisal, my first question would be if the results of the trial are valid. So, was assignment of patients to treatment randomized? Yes, the assignment was centrally randomized and stratified by trial size and type of surgery. Were the groups similar at the start of the trial? I would say yes, except for preoperative hypertension and creatinine concentrations, which were lower in the combined epidural general anesthesia arm. Aside from the allocated treatment, were groups treated equally? Yes, they were. Were all patients who entered the trial accounted for, and were they analyzed in the groups of which they were randomized? Yes, the loss in follow-up was less than 20% in both arms. Patients were analyzed with intention to treat analysis. Additionally, authors also performed a per protocol analysis. Were the patients and clinicians kept blind to which treatment was being received? Well, no. For pragmatic reasons, participants and care providers were not masked from group assignments. However, investigators who perform postoperative follow-up and outcome assessment did not participate in perioperative care and had no knowledge of treatment assignments. Authors nevertheless recognized that blinding was surely imperfectly. And finally, what were the results and how large and how precise was the treatment effect? Well, all the patients randomized to combine epidural general anesthesia for major thoracic and abdominal surgeries had 1/3 as much delirium compared with the general anesthesia arm. In terms of precision, the interval confidence is fairly narrow, so we can be confident that the point estimate is a precise reflection of the population value. Regarding the number to treat, we would need to treat 31 patients in order to prevent 1 delirium. For reference, postoperative patients who received peripheral nerve blockade had an NNT to prevent delirium of 14. Another example for your reference would be the NNT of vitamin D for preventing hip fracture in elderly institutionalized patients, which is 36. Finally, with regards to the clinical significance of these findings, we can conclude that although the treatment might be feasible in our setting, we should keep in mind that the population included in this study was younger than our patients. They also have fewer comorbidities and a better baseline with regards to their MMSE. Therefore, the risk of delirium in this population might also be lower. Another issue that may be relevant is that although this trial had a large number of participants, the observed rate of delirium in the control group was lower compared to previous studies. Thus, from the perspective of outcome events being evaluated, the trial is relatively small. However, I should mention that there are also some benefits of combined epidural general anesthesia, including the use of fewer anesthesia drugs, better pain control, lower use of opioids, and a reduction in stress and inflammatory responses. All of these might contribute to decreasing the risk of delirium. As a final comment, although in this trial, all the patients randomized to combine epidural general anesthesia for major thoracic and abdominal surgery had 1/3 as much delirium compared to those receiving general anesthesia, they also had 50% more hypotension. So the benefits of combined epidural general anesthesia need to be balanced against the potential risk of hypotension on an individual basis. Thank you so much for your time and for the opportunity to present in this journal as part of my fellowship. I'm open to any comments. Thank you very much.
Thank you very much, Maria, for the excellent presentation and the clarity that you delivered it. That was wonderful. Thank you. Gary has his hand up. Go ahead.
Maria, thank you very much for that really clear, interesting presentation. Perhaps I'll start by stating the obvious. We really, in this study, studied 2 different interventions. We studied intraoperative anesthesia and postoperative pain management. And Maria, as you well know, the ideal study design to study this would have been a factorial design where you had the 4 permutations and combinations of the general anesthesia and postoperative pain control, because that would have been the only way for us to really understand which elements were having the most significant impact on the outcome of interest. Because barring that, we don't know, and you're either doing the package or not, if you want to try to have the benefit. Can you confirm to me the issue about hypotension, are we talking about primarily intraoperative hypotension? And can you tell us what the clinical importance of that? Obviously, it required some treatment, but were there serious consequences for people who experienced the hypotension?
Thank you for your comment and your question. Yes. So yes, it's for the hypotension, they require more colloids, but we don't have so much information about it. So I think that it's something that is really, I will really consider if I have to think about this trial in my patients.
Thank you. And Maria, I might also question, do you know how long the epidural remained in place post-operative? Similar to Guillaume's study, it would have been nice to have functional outcomes, because I imagine a tether to the catheter and the pole may reduce the functional outcomes, although as you noted, the patients were quite young and cognitively very well at baseline.
Yes, I have the same question, and I tried to find for how long they have the epidural catheter, and I couldn't really find it, to be honest. There are also some patients that they were discharged before the 7 days, and they only mentioned that they called them. So I assume that there are some patients that they receive the epidural anesthesia for lower time. Yeah.
And along those similar lines, the mechanism that appears to be theorized is the opioid use. Did they clearly describe the post-operative opioid use in the two groups with doses and duration?
Yes, and also that part is really interesting, because one of the groups received continuum morphine, and when they compare, for sure, the other group received less morphine. So they compare. So in other words, they compare separately if they receive extra doses of morphine in the TA group, apart from the continuous morphine. I mean, that was also really interesting for me, then, that they do it in that way in the trial.
Thank you. Any other questions from the audience? Or comments in the chat? If not, I will thank both speakers very much. By chance, the topics aligned. And Maria, also thank you for the clear graphics representing the various types of anesthesia. I think that was very helpful for the audience. And thank you both for two wonderful presentations. By way of announcements, the Journal Club evaluation email should have just been received. Please remember to complete them. And next, or this coming Wednesday, June 1st, is our Divisional Research Day. And I hope to see you all online for our Divisional Research Day. Thank you again, both Guillaume and Maria. And I wish everyone a great day.